يعطيكم العافية جميعا. إن شاء الله في عنا اليوم هيك كيس بسيطة عن موضوع أخذناه الأسبوع الماضي مع الدكاترة، وإن شاء الله نستفيد. First of all, we will read the case, review the questions, and then revisit the case to highlight the important stuff written in it. A 19-year-old prima gravida at 29 weeks of gestation arrives at the hospital because of she is complaining of severe dyspnea for 6 hours duration. Her parental course has been unremarkable, and she denies any medical problems. Her blood pressure is 160 over 114 millimeter mercury. Her heart rate is 105 beats per minute. Respiratory rate is 40 breaths per minute, and it's labored. It's difficult with great effort. The oxygen saturation is 90%. The fetal heart tones are in the range of 140 beats per minute. A urine protein to creatinine ratio is zero point 0.6. The serum ALT is 84 international units, and the AST is 90. The parental records on the previous visits shows the following. On 8 weeks, it was taken on 8 weeks, on 12 weeks, on 16 weeks, on 20, and on 26 weeks gestation. Now, we would like to ask, what is the most likely diagnosis based on the history you have heard? What is your immediate next step? And what are the priority laboratory tests that we should do? And what is the management plan? To revisit, just a quick revisit to the history, we find that the patient is in the extremities of age. So she is below the 20-year-old, so she's 19-year-old. She's prima gravida. She is at 29 weeks gestation, so she is in her third trimester. Her chief complaint is dyspnea for 6 hours duration, so it's acute. Her blood pressure is severely elevated. It's an emergency, obviously. More than 160 over 110, so it's severely elevated. Her heart rate is 105. It's also elevated. Her respiratory rate is 40, which is also elevated. And the way she breathes is very difficult, and her oxygen saturation is 90. We from these vital signs we conclude that she is unstable. Her heart rate and her blood pressure in particular is very high, and her oxygen saturation is a bit low. The fetal heart tones are in the range of 140. From that we can conclude that the fetal is doing well, relatively speaking. Um, she has protein in her urine, so it is she has elevated protein to creatinine ratio. Normally, it should have been 0.2%, and the ALT and AST are both way over the normal limits. And from the previous paternal visits, we can find that 3 weeks prior to her presentation at 26 weeks, she had borderline elevated blood pressure and +1 on the urine dipstick. So that indicates proteinuria. So it was preceded by a borderline elevated blood pressure. So she should have probably been um, managed differently, or at least had a revisit 1 week after the last visit. So she should have went to check up at least on her 27 week. دكتور حاب تضيف شيء ولا ننتقل على الأسئلة؟
Yeah, لا في few things. أنت قصدك prenatal rather than parenteral. uh, prenatal أو antenatal مقصود فيها during
Sorry, sorry.
pregnancy. That's all right.
Prenatal.
السؤال الثاني إنه where did you get this history from?
From a book of cases, doctor.
Mhm. Okay, although it's not a very typical presentation for preeclampsia, يعني from the first يعني هيك insight, you would probably think that this patient might be having يمكن PE أو
Yes.
why she's having that drop in the oxygen saturation. أو how do you explain it؟ بس أوكي أنا بحب أسمع، تفضل كمل.
تمام. The fetal heart rate or fetal heart tones are all in the normal range, and the fundal height is the last time checked at 26 weeks is also normal. Normal range at 26 weeks, I think is between 24 and 28 centimeters. So it is good. Now, moving on, what is the most likely diagnosis? Uh, doctor said it's not a typical presentation, but as far as I know, the typical presentation of preeclampsia is primigravida, young or extremely old female, and presenting in her third trimester with elevated blood pressure and edema. That's the classical presentation that I know of. Nulliparous woman in her third trimester. So the our diagnosis is preeclampsia with severe features. The first thing we should do is to manage her oxygenation. The oxygen saturation should be elevated. So we should give that the highest priority. We should at least achieve a goal of O2 sat over more than 94%. Again, in parallel to that, we should also try to lower her blood pressure with IV drugs. We usually give the labetalol and hydralazine for the blood pressure. Now, again, as the doctor mentioned, such breathing pattern and respiratory rate, along with a low oxygen saturation, we might think of IMA PE or from the hypertension or pulmonary edema. So, if we suspect pulmonary edema and if it is confirmed, IV diuresis such as furosemide should be given. We should prioritize again the laboratory tests. Regarding the laboratory test, why did we say this is severe preeclampsia or preeclampsia with severe features rather than it's not HELP syndrome? Why it's not HELP syndrome? Well, because we do not have for the diagnosis of HELP syndrome, we should have evidence of hemolysis, of hemolytic anemia, and low platelets. So to exclude that or to know whether the patient has reached such a worse diagnosis, we should do the first thing we should do is CBC to check for the thrombocytopenia. We should also do a renal function test, the to check for the creatinine because to know whether the patient has reached some sort of end organ presentation or end organ failure in severe preeclampsia. The management for severe preeclampsia in general, if the patient is unstable, the first thing we should do, of course, the patient is unstable. She is having severe preeclampsia. We should stabilize and then deliver. Now, in stabilization, again, we mentioned we should optimize the oxygenation, lower the blood pressure using labetalol and hydralazine. We should stabilize the fetal status. In our case, all the inputs that we had, that the fetal status was good, the fetus was in good condition, we should administer corticosteroid, mainly talking about betamethasone. It enhances the fetal lung maturity. We should give magnesium sulfate prophylaxis. The magnesium sulfate is given on a loading dose and a maintenance dose. بس دكتور هون صراحة بدي أسألك سؤال. أنا قرأت إنه اللودينج دوز 4 grams and maintenance dose 1 gram per hour. But this is the new, I think, guideline, and the old guideline was 4 to 6 loading dose and 1 or 2 maintenance per hour. شو اللي احنا بدنا نعتمده دكتور؟
مش شايف في فرق أنا so far.
نعم دكتور.
I can't see any difference. يعني وين الديفرنس بين 4 أو 4 to 6 وبين 1 أو 1 to 2؟
يعني اوكي.
To start with, the second thing is, would you consider magnesium sulfate in this situation?
Yes, doctor. Before delivery, we should always in patients with mild or severe preeclampsia, the patient should be given magnesium sulfate and up to 24 hours after delivery.
Okay. Magnesium sulfate is not given for mild cases. It's only given for severe cases. واحد. Magnesium sulfate has a very narrow therapeutic index, and it needs to be given in the presence of a normal kidney function test. 3.
Okay.
In somebody who is having abnormal oxygen saturation, as one of the important problems related to magnesium sulfate is causing cardiopulmonary suppression, you wouldn't probably be very happy to start magnesium sulfate. This is regarding magnesium sulfate. On the other hand, you probably think that this patient is having a severe preeclampsia. In severe preeclampsia, what you need to do, as you have mentioned, you need to stabilize the patient, control her blood pressure, avoid seizure or prevent seizures, and then deliver. And this has to be within like a few hours. If you are planning to give steroids, then you need to wait for probably 48 hours for these steroids to act. And I will not be interested to give steroids for somebody who is having pulmonary edema, because this is going probably to worsen her condition. So steroids is not probably one of the good and nice things to be given for this patient. So steroids is given in probably what we call it mild to moderate cases. While in severe situation, as in this patient, she's having a severe preeclampsia because she has developed one of the most important, well, it's not the most common complication of preeclampsia, which is pulmonary edema. So this patient is certainly severe preeclampsia, and delivery should be within few hours. We don't probably need to give steroids because steroids will not be acting on the first hand, and second, probably it might worsen the situation. تفضل كمل.
تمام. So in this case, we do not give corticosteroids or magnesium sulfate for seizure prophylaxis. طب دكتور, how do we manage seizure prophylaxis in such patient?
Okay, you probably can try other medications like phenytoin, like midazolam or diazepams. Probably they are not as efficient as magnesium sulfate, but I don't think magnesium sulfate is an advised thing in this situation. This is number one. Number two, she's not having an extreme high blood pressure. It's about 160 over 110. So yeah, probably you actually need to concentrate more is the delivering the patient as quick as you can.
تمام. شكرا دكتور. The delivery, just quick notes about the delivery. We opt for vaginal delivery. Cesarean delivery is only indicated for obstetric conditions only. So if there's indications of CS other than preeclampsia, regardless of the preeclampsia, then we do CS. We try vaginal delivery, maybe with the assistance of prostaglandins. دكتور, another point صراحة بدي أسألك عنها دكتور. I read that in severe preeclampsia, but without end organ damage, without pulmonary edema, without renal failure, acute, and if the patient is between 24 and 32 weeks of gestation, can we manage with expectant management plus betamethasone?
You are trying to make the situation difficult for you. It's easy. If it's mild, this is it has a management plan that is totally different than severe, regardless of the gestational age. Okay, so just ignore the gestational age. If this patient is 26 weeks and she's showing severe preeclamptic condition, the answer is the same: stabilize and deliver. If this patient is having a mild situation, then what you need to do is probably control her blood pressure, enhance lung maturity, increase the surveillance, and probably deliver her whenever you feel that this patient has turned to be a severe one.
دكتور, عندي سؤال سريع على شيء حكيتوه بخصوص السيجر بروفيلاكسس. دكتور, انت حكيت انه ممكن نستخدم فينيتوين بدل المغنيسيوم سولفيت، بس ليش ما نستخدم لاموتريجين؟ لانه الفينيتوين يعني ممكن يعمل مالفورميشنز اكثر من اللاموتريجين، واللاموتريجين
هنا ما عندنا تراتوجينيك افكت بهذا الجستيشنال ايج. احنا we are far away from any teratogenic effect that might occur. This is number one. Number two, you are going to administer this medication few hours before her delivery. And in most of the cases in this situation, it's going to be cesarean section. I totally agree with you that cesarean section is not an indication to deliver preeclamptic women. Yes, I agree, but you probably need to go and opt the easier and probably the quicker option of delivery. In a situation like this, in her 26 or 28 weeks, and she's primary gravida, you would expect her delivery, if you are planning a vaginal one, that will take probably 1 or 2 days, and this is not true. So if you think that, according to the Bishop's code, that this patient is not going to deliver soon, then probably cesarean section might be the safer option.
تمام, شكرا دكتور.
عفوا.
تمام دكتور. بس أنا هذا اللي عندي دكتور. إذا في عندك أي تعليق أو إذا في أحد عنده أي سؤال.
هل عندك سؤال؟
بقول دكتور أنا I rest my case. هذا اللي عندي دكتور. فإذا في عندك أي تعليق أو أي سؤال
حدا عنده سؤال؟ طيب. Again, this is one of the complications of preeclampsia اللي هي pulmonary edema. But again, this is not the typical, this is not the usual, this is not the daily presentation of preeclampsia. Although, yes, I agree that this patient is having some risk factors of being young, of being teenager, and of being a primary gravida. And she is now in her 3rd trimester. Let's talk a few things about the pathophysiology of preeclampsia. So preeclampsia has been known decades ago to cause problems, maternal morbidity and mortality, and neonatal morbidity and mortality. The exact cause behind it is not well understood, but we all agree that it's related to the placenta. Because once the placenta is out, that problem or that cascade of problems should end. So we all know that it's a placental disorder that is probably secondary to the abnormal implantation of that placenta into the endometrium is causing to release or to pulse certain toxins, as its older name implies. It was used to be called pre-toxemia or pre-toxemia. So probably there are certain toxins released, and these toxins are causing multiple pathophysiological entities. So one of them is causing generalized vasoconstriction all over the body. So one of these vasoconstriction can be manifested easily by just measuring her blood pressure, as her peripheral blood vessels are responding to these vasoconstrictors, and it will show high blood pressure reading. So this is probably the easier thing to look for the exact entity of preeclampsia. The second pathophysiological entity is causing endothelial injury. So probably that can explain why these patients might develop hemolytic anemias, HELP syndrome, and deep vein thrombosis. The third entity is causing increase in the vascular permeability all over the body. So one of these effect can be either pulmonary edema, cerebral edema, everywhere edema, and at the same time, that will cause an increase in the hematocrit level. That will secondarily cause deep vein thrombosis. So these are the three pathophysiological entities. And we don't need to forget here that uteroplacental circulation is part of the circulation that is going also to respond to these substances. Therefore, the baby might show signs of uteroplacental insufficiency. The baby is not receiving adequate blood supply secondary to the generalized vasoconstriction the patient is having, and therefore the baby might show growth restriction, and then eventually fetal death. And if that occurred, then this patient is having a severe preeclampsia. This is regarding the fetal circulation. Let's go back to the abnormal implantation of the placenta into the endometrium. We will call this a diseased placenta. There's a generalized or a group of diseases that share the same pathology, which is abnormal or diseased placenta. When I have an abnormal or diseased placenta, I do expect that this patient might have problems related to preeclampsia. I do expect that this baby might have some sort of growth restriction or even intrauterine fetal death. I do have some queries or expectation that this patient might have placental abruption. Yes, we know that placental abruption can be a secondary or a complication related to preeclampsia, but sometimes it can occur without high reading of blood pressures. And this is probably related to, again, the same entity of having abnormal or diseased placenta. So the aim, our aim of dealing with this situation, whenever I have a patient that is probably having preeclampsia, and as we said, the easiest way to look and to monitor preeclamptic problems is just by measuring her blood pressure and just by looking at the urine protein or urine protein creatinine ratio, because it's an easy thing, rather than going and look for pulmonary edema, cerebral edema, glomerular endotheliosis, and so on. So these are the easiest things that we can do in the clinic. So in the clinic, it should be, as mentioned here at the table, that we need to look for her blood pressure every visit. We need to look for her proteinuria in every visit. These are the easiest things that we can look for preeclampsia. And again, we need to define those patients who have the highest risks. We need to define the high-risk population for preeclampsia and pick them up, look for them carefully, and try to define what kind of preeclampsia she's having. Now, whenever she's having high blood pressure or hypotonuria, we will start our investigation. Now, this investigation should be directed toward defining whether this is a mild or this is severe preeclampsia. Because if this is a severe preeclampsia, as we will talk in a few minutes, then you need to stabilize the patient and deliver her regardless of the gestational age. Now, severe preeclampsia is not only high blood pressure, is not only high proteinuria. It can be, yes, increased blood pressure, but it's not more than 160. It's probably 140 or 150 over 100 plus symptoms. So anything that's more than 140 over 90, this is abnormal. But this can be mild. While if that 150 over 100 was associated with symptoms, then this is severe. If this patient is having other symptoms like gastric pain, headaches, blurred vision, again, these are need to be considered and probably upgrade the situation from being mild up to being severe preeclampsia and deal with her as severe preeclampsia. Examination will add much to your diagnosis to know whether this is mild or this is severe. Listen to the chest, look for pulmonary edema, look for hyperreflexia in these cases, and this might be a sign of severity. Look for epigastric tenderness. Look for the fundal height, whether it's high, low, or listen for the fetal heart rate, and probably this baby has been growth restricted, and then probably we need to upgrade her situation of being severe one. The third issue is we need to look for her investigation. So history, examination, investigation, all of these things are going to be collected to find out whether this patient is mild or this patient is having severe preeclampsia. If she's having mild, then we need to increase her surveillance. We need to monitor her carefully. We need probably to enhance the lung maturity because we do expect that this patient might not be able to reach term. And then you probably might be able to give her some antihypertensive, oral antihypertensive medication, but this situation is very debatable. The timing of delivery is the earliest that you think that this pregnancy will be. So, for example, it's going to be between 37 weeks, 36 weeks, 37 weeks, something around this gestational age, because we don't want these hair complications to develop. Something important that we need to know in preeclampsia. Preeclampsia is a progressive disorder. Preeclampsia doesn't stop where it has started. Preeclampsia will end up, if you just leave the patient alone, to have or to develop complications. But we don't know exactly when these complications might develop. Therefore, you need to respect that progression of her disease and monitor her carefully and stop her pregnancy whenever you think whether she has reached term or whenever you think that this preeclampsia has been turned to be a severe one. This is regarding how do we need to manage the situation. Of course, what Amr has mentioned regarding how to stabilize the patient is very understood in terms of giving antihypertensive medication, in terms of preventing seizures, in terms of monitoring of the fetal well-being, and then arrange her delivery. And we have mentioned how to deliver this patient. If she's para 5, for example, and she's about 3 to 4 centimeters dilated cervix, then we probably can go for vaginal birth because we do expect that, according to the Bishop score, that she's going to deliver soon. Well, if a patient like this one, 29 weeks, primi gravida, she's having severe preeclampsia, we need to end this pregnancy soon. We don't expect her, according to the Bishop score that she's having, that she's going to deliver probably in the first 12 to 24 hours. So at that time, probably cesarean section might be a safer option for her. That was regarding the preeclampsia. Let's talk about few words about this patient. For example, after ending her pregnancy, can she develop preeclampsia in her next pregnancies? The answer is certainly yes. Can we prevent her from having the same situation or the same problem again? Probably yes. If we define the high-risk population and we probably administer baby aspirin 100 milligram before 16 weeks, then probably we would be able to prevent preeclampsia in the future. This patient in the periperium might be at significant risk of having deep vein thrombosis. Therefore, talking about contraceptive measures especially avoiding the pills might be a good behavior or a good attitude. I think I'm not going to teach you everything regarding preeclampsia, but I think it's important to figure out what's going on regarding preeclampsia, and then this will help us much in terms of how to deal with preeclampsia. If you have any questions, I'm ready to answer. No questions؟
يعطيك العافية.
يعطيكم العافية جميعا، شكرا جزيلا.
يعطيكم العافية.
يا هلا بك.